Good afternoon, everybody. Welcome to our December telehealth. I first, real quick, so that she doesn't have to stay up here too long, many of you here in the room have already met Kylie, but I wanted to introduce Kylie to you. She is the new PRC assistant, and we're very excited to have all of her energy here. And so, yeah. So I just wanted to introduce her, and if I can no longer tell the joke anymore that if somebody else answers the phone at the PRC, call the police. Because hopefully it's Kylie now. So, but if you call, one of us will be there for you. And thank you very much.
Yeah, thank you.
So, let's see. Next month. Real quick before we start, next month's topic is going to be tools to handling stress in our lives. And January is always an interesting month when it comes to stress. We've just got done with the holidays. Bills are sometimes higher. The winter depression, a lot of different things. So our speaker next month will be about tools that you can use to handling your stress and helping in relaxation. And it'll be a very good talk. Just wanted to let you know. And I can't think of anything coming up except for, oh my gosh, there's the holidays. But the new year is right around the corner, and the new calendar will be up about halfway through the month. So go ahead and look on the website at www.spokaneparkinsons.org for the new website or the new calendar soon. And for all of our sites who are logged in or who are logging in, after our talk today with Mr. Gates, we are going to do a sing-along with our Tremble Clefs. Sorry, I have people talking to me in the audience. And Ruth. What? I know. I was going to read the whole thing right here. Sheesh. Just teasing. So at the end, if you would like to stay after our question and answer period, please do so. Unmute your mics at the end after all of we'll let you know, and you can sing along with us in the Tremble Clefs. So this is kind of long, and I apologize. You probably don't want me to read the whole thing, so you can cut me off anytime. But Dr. Brian Gates is the doctor of pharmacy at WSU. He has a fellowship in geriatrics and the Providence Visiting Nurse Association of Spokane. Dr. Gates' research focuses on helping patients avoid adverse drug reactions related to medication use, with current emphasis on preventing drug problems caused by non-steroidal anti-inflammatory drugs like NSAIDs, as well as research into potential barriers preventing home care patients from receiving treatment for deep vein thrombosis and pulmonary embolism. Dr. Gates is also a member of the WSU Geriatrics research team, but I also have to say you may remember him from a telehealth a little while back where he was part of a panel, and we're very thankful that he is around for us to ask questions. When we have somebody who calls the PRC, I'm not a doctor, I'm not a nurse, and if we have questions, Dr. Gates is one of the people that lets us email him and say, okay, we had this question about cold medicine. So we're really appreciative to have him around, and I'll go away now. Thank you.
Is this one on? You can hear me? Well, I'm glad Cindy said that, because I thought I was just here for the sing-along, so I guess I better come up with something quick. But, no, it's nice to be back, and as Cindy mentioned, I teach with the WSU College of Pharmacy, and we're also fortunate that some of the attendees in the audience here today have even come and spoken to our pharmacy students before, and they really appreciate that. So I'm happy to be here and discuss medications a little bit. And what I have today is just fairly brief, hopefully a lot of time for questions. And as you'll see here, there's a few more specific things that I was originally asked to address. But obviously with medications, there's always a lot we could talk about, especially as you get into side effects and problems with medications. So please feel free to ask me those, and I'll try to answer them as best I can. But also, even if we start some discussion, I always think that's great too, because I will say, as we get into with medications, everybody's different enough that there are things we learn from each other, and I learn a lot from the people with Parkinson's I talk with as well, just in how the meds actually affect them, just because everybody is different. So keep in mind with what I tell you, I'm giving you some of the general information, so please feel free to shoot your hand up and say I'm wrong if you think you've experienced something different. We'll talk about that. And I will give you an idea too, for those of you who didn't know, I want to dedicate this to Dr. Steve Setter. Some of you may know, who worked with the Parkinson's Resource Center for many years. I trained under Steve, and so he was really the one who taught me a lot about Parkinson's and working with the medications, and so I wouldn't be here if it weren't for him. And I also, like Steve, work in home care, so that's been my main area. So we're both considered to be in geriatrics, but we work with a lot of people in the home and make home visits, so that's the point of reference I come from in doing this. So I mentioned this would be brief, but just a couple points here. We're going to just talk briefly about the process for developing new medications, because that was one thing that I was asked to talk about when the Food and Drug Administration is approving these meds that you see show up in the paper, or if you see one that you've heard about, boy, this new medication might be coming out, but then it doesn't, something happens. Just talk a little bit about what goes on behind that. And then we'll also talk a little bit about side effects for some of the Parkinson's medications. And what we'll try to do today is focus on those where maybe we can discuss a little bit about what you might do. So rather than throwing out a full list of side effects like you might see if you watch, certain shows, you get the advertisement on there that they talk about 37 different side effects and you're afraid to even get near it by the time it's done. We'll try to talk a little bit about some of the key ones, and certainly with that, feel free to throw in experiences you've had if it relates to that as well. So making new medications. So partly why we get asked this question is, why are drugs so expensive? And this can get to be a fairly complicated topic. But on the basic gist is that there are different stages, so that's both why it adds to the cost, and also sometimes while you hear about these drugs, as I referred to, that may not make it to market because they have to get through certain testing. And as you'll see there are a fair number of medications that get viewed at some point and then don't make it. Sometimes they look really good in animals and don't work very well in humans, or other times they work well, but unfortunately have a side effect that we don't realize until they get a little further into testing. So a little bit more about this, and I know this is a lot of detail. Cindy will be able to get the slides out later. But what I want to basically show you, though, what this is talking about here is there's some different phases. This first one is what they call the preclinical. And for the FDA, what that means is that's more in the laboratory where you've got scientists actually trying to find compounds that might potentially work as medication. So they've got a few averages here, and this is just to give you some idea. This is why I like this one. They say if you've got a medication that they're trying to develop, it usually takes about 6.5 years to get it from the early stage to where they might actually be testing it. So that's partly why you'll see sometimes that we've got this great discovery, but they say it might be 10 or 15 years before a drug is even available. Sometimes when they find something, there's a lot they have to do in the background. What they notice, you may note here, I know it's hard to see, but they talk about 5,000 compounds being evaluated. So, there's different stats on that, and it'll vary, of course, for different medications, but you may have 5,000 for every one that actually makes it through. So that's kind of where you're starting. After that, if they've got something that looks pretty good in some of their early tests, and that includes where they do some of the animal research early on, they go to these different phases. And there's 3 of them that they'll talk about with trials for the meds. And basically what happens there is initially they'll do healthy volunteers, which to translate that's a starving college student who's trying to make a little more money. But they do it first in someone who's otherwise healthy, so they're trying to make sure that if it's going to cause a problem, they can hopefully catch it rather than giving someone maybe who has some other illnesses where they might be affected a little more. If it's okay there, they move into some smaller studies where they got volunteers for what it's actually trying to help with. So in this case, it would be someone who has Parkinson's at that point. And they throw out the number of 100 to 500 volunteers. they'll study that more closely, and then if it works well and there are not problems there, they'll move on to larger studies where usually they'll have 1,000 to 5,000 people. And we work a little bit with this at the college. Sometimes to get these numbers, you've got to have places all throughout the country to get enough people to get those numbers that the FDA will want. And that's what sometimes adds into some of the cost. What it throws down here is that of those 5,000, about 5 of them actually get to the trial. So that's giving you an idea of all the work to get one. And then if after all of these trials, the companies have to give the information to the FDA, and the FDA tries to look at all of that information, which takes a while, usually at least several months, sometimes even a year or two, depending on what they find. And then after it's been on the market, they have some studies that they're doing as well. So you may see for a while, in some cases, a medication will be out on the market, and then it will actually get pulled off because of problems that they have. And so they do have to watch that as well. Just an example of that is the patch, so the dopamine agonist. Some of you may remember if you were on I'm trying to remember now if they called that New Pro at the time, but it was out for a while, and they found some people it didn't work very well because it would start to crystallize within the patch. So that's kind of this process where it worked well, everything was fine, but after they had enough people taking it, they noticed additional problems. So that's where you'll get why some of those things will get medications will get pulled off the market, as we say, after a while as well, because they find problems when they're out there in practice. So that's kind of a basic gist. Now, does that answer exactly why the medications are so expensive? Well, it's part of the process. There's always a lot of debate with that. How expensive do they need to be? It can depend sometimes on how much of this research is done by the company, or occasionally you'll find even maybe universities will do that. They'll get a grant, say, from the National Institute of Health, who will say, we need to research this. Universities will do that. Sometimes after that grant, they'll find a medication, and then they can actually pass it along to a company who has the ability to do the trials and those kind of things, which may cut down sometimes on the cost, but not always. And so that's one reason they're so expensive. Obviously, the companies are still trying to make a profit as well, so that adds in to that total cost, and we get some debate about do they need to be that expensive. But that's a little bit what it goes through. So this whole process can take several years, and there's a lot involved in getting that medication developed. But any questions about that? Is that helpful to some extent? Okay, yeah.
Why are they cheaper in Canada than here?
Great question. Why are they cheaper in Canada than here? Well, the simple answer to that, and people may disagree with me a little bit, but in all honesty, the United States funds a lot of this. So the companies can still make money, say, selling to Canada or to Mexico, other places, beyond what it costs them to make the medication. We pay for a lot more of this, if that makes sense. So at least at this point, that's where the U.S. takes a lot of that.
Is that fair?
Well, I don't think so. I mean, it is a big topic, and it's a very good question. And that is one that has been of debate, even with some of the healthcare reform, that there's not that chance for the United States or the plans to negotiate a little bit more with that, which is, one thing that's certainly up for debate, and I think would be more fair. And part of the reason Canada does have it cheaper as well is with, essentially with the one system. And obviously there's debate about the different aspects of that. But for the meds, they have a little bit more negotiating power. And the companies are willing to do that since they can still make money off that.
Thank you.
Mm-hmm. Any other questions on that?
Yes, I have a question.
Sure.
In Tenasket, and the new Pro patches, you said they have been pulled? Are they going to be pulled due to the crystallization on the patch?
Oh, I'm sorry. That's in the past. So they're available now again. They've worked on that. So if you're taking that now, it's not going to be pulled off the market at this time. That was in the past where they were on the market for a while. Because of those problems, they had to be gone for a while and get reformulated, and now it is available again. So no problem if you're on it now. Sorry, I should have clarified that.
Are you familiar with the drug Erazepam that's going in a phase 3 study group with Fox Foundation? It's already Erazepam. It's already approved as a high blood pressure medicine, but they're now doing studies at phase 3 for use for Parkinson's.
You know, I'm not familiar too much with the Parkinson study on that. I do know which medication you're talking about, though, for blood pressure. So I don't know a lot of the details, or at least how it would be helpful. But if it is in phase 3, it'd be in that larger testing study. So hopefully, depending on when that was started, the FDA may get the results of that within a year or two, hopefully.
It's a calcium blocker.
Yeah.
All right, thank you.
Yeah, I don't know a lot about the information on that, to tell you the truth, or how well it's working at this point.
Okay, thanks.
Any other questions? Okay.
It doesn't work. You're right. It doesn't work now.
Yeah, I didn't think so.
All right, well, we'll talk a little bit about the side effects from the medications. And this first slide is very general, but something I think is very important to discuss, because I'll often get people who will tell me, well, my doctor, my nurse practitioner said, we may want to try this, and they were given some information, and you kind of look at that long list of side effects again and say, wow, I don't think I want to get all these side effects. And why I come back, what I mentioned earlier, where everyone is different, is that it's very interesting as you talk about side effects of medications, because there are some, like a lot of them that we'll talk about today, which may be side effects that we may expect based on what we know about the medications. But again, some side effects are simply how someone's body responds to a medication. So as we look at what we understand about the medication, we don't always know exactly why that's happening. And one that does drive some people crazy when they ask me about it, they said, well, this is dumb. I looked at this medication. It says it can cause constipation or it can cause diarrhea. Can you guys make up your mind? Tell me what it's going to cause for me. I said, well, sometimes we know that some medications are more likely to cause one or the other. But that's one of those situations where it depends on how sensitive somebody is. And the best answer may not always be satisfactory, but for an individual person, the way somebody responds, that particular medication, once it gets inside their digestive system, it's going to cause constipation. Other people, their digestive tract says, boy, what in the world is this? It bothers them, they get diarrhea from it. And so we do see those kind of things as well. So I just mention all that to recognize that everybody will be a little bit different with side effects, and why it's also important then to really talk with the prescriber, whoever is giving that to you, if you think you're getting some of those side effects. And as we talk a little bit today about what can be done about those, hopefully it gives you some idea what you can discuss with the prescriber, but making sure that communication is there, because we do find a lot of times where, as I mentioned, somebody is worried about that list. They may not even start the medication, which causes problems later on if the prescriber is changing medications, assuming a medication is being taken when it's not. Or if somebody's on a different dose, etc. But also, we don't want people to necessarily just stop the medications as well. There are some times, especially if the dose has been increased and the meds have been taken for a while, it may be very important not to just suddenly stop it. And one that I have down here as well is if someone seems to be really sensitive to medications, it's important to let the prescriber know too. And hopefully the prescriber always listens. I know some may do a little better job of that than others. And it doesn't always mean somebody's going to get side effects if they're more sensitive, but sometimes, kind of tying in with the next part, we'll just go a lot slower. Sometimes a half a tablet or even a quarter of a tablet sometimes, if that's feasible. Obviously, sometimes they'll get pretty small. And it doesn't mean that it's going to stay there. So I'll get people say, well, a quarter of a tablet, that's not going to do any good for me. For some people, it might. But in some cases, even if we don't think that's going to work to, say, help symptoms, it may actually be enough just so somebody can get used to the medication a little bit and then can tolerate more later on. And in some cases, even if someone got started on a med and it's causing a lot of side effects, sometimes we can go back and use a lower dose for a while, let somebody get kind of used to it, and then go up a little more gradually. So I do want you to keep that in mind. And that kind of ties in those last ones, going slowly and not being stuck on that lowest dose too. Doesn't mean that you're always going to be there. Steve Setter, as I mentioned earlier, I don't know if any of you saw, he used to have bumper stickers he would make for a few things. I don't know if he presented any to you, but he said if there was a bumper sticker for geriatrics, it would be start low, go slow, but still get somewhere. And what he meant by that is that sometimes people forget to start low. We start somebody too high. And even if we do that, sometimes we still try to go too fast. You know, maybe the standard for everybody says you should increase the medication every 3 days. Some people may have to go even a week. But on the other hand, I've seen somebody say, oh, well, they start on a low dose, they're probably sensitive, we better not increase it. So somebody gets left on a dose that's too low. And we've run into that before. And I'm not joking, this not so much with Parkinson's, but we've run into times when we've had somebody on a medication fairly low, it didn't seem to be working. We've asked the prescriber to increase it, and they say, oh, they're already taking something, it should be just fine. And I'm not quite sure where that comes from, but we may just have to go up really slowly. And so that last piece there, just again, advice. So keep in contact with the prescriber, and also just about the risk and benefit as well. And that's one thing I really want to emphasize today also, is that for each person, as we call the risk and benefit, may be different. So sometimes what we're trying to find out, depending on the problem someone is having and what we're trying to do with the medications, it may be more important to try to keep the medication and manage the side effects as best we can. At other times, it may be better to see if we can use a different medication. It really just depends on what we're trying to accomplish with the medication and how much of a problem those side effects are. So jumping in a little more to the specific ones, again, feel free to ask me if you have any other thoughts. One I start out with is the Carbidopa-Levodopa or Sinemet. And one of the most common complaints people have is nausea, especially when they're first getting started on it. So you may see here one that can help is taking it with food, but one question can, not everybody. And we'll get to what else we can do in a second. But one thing about the medication that some people will ask and they hear about is they say, well, doesn't food make it not work as well? Well, it can, but there are a few little caveats or tips we have to talk about with that. One is that the problem is usually protein. So, thinking about meats, and so, this time of year as you're getting ready for Christmas dinner, ham and turkey, things like that. Protein can be more of a problem than just other foods. So say more breads, grains, things like that. However, especially if somebody's already doing well and they've been taking it for a while, doesn't mean now that, say somebody takes it with lunch every day and they have a turkey sandwich, don't tell them, well, they can't do that anymore. What we do find is that, especially early on, when somebody's first starting on the Sinemet, maybe earlier in the diagnosis of Parkinson's, it doesn't seem to matter very much if they have some protein or not. Just mainly because usually when somebody's first started on the Sinemet, they'll respond pretty well to it. Where it sometimes is an issue is more later on if somebody's on, say, higher doses of the Sinemet and they're trying to work with maybe some of the short-acting to manage the on-off symptoms to match the right time. In some of those people, we will see that protein might have more of an effect than if they eat something without protein. So kind of the bottom line is it doesn't mean that somebody can't have protein, but we try to watch it. Maybe if you're going out to eat, don't get the triple baconator at Wendy's if you're going to be taking your Sinemet at the same time. But if we try to be reasonable and spread things out, it might help. The other one is that sometimes we get this question as well. The carbidopa that's in there, you may notice Sinemet's the combination. Carbidopa really doesn't help much with the actual, as we would say, Parkinson's itself. Levodopa is really the beneficial medication, but the carbidopa does play an important role in letting the levodopa do its job. And to kind of simplify that and tell you what this has to do with nausea, though, is that what happens is that without the carbidopa, the body recognizes levodopa pretty quick and basically changes it into dopamine. So, and you may know dopamine is really what we're trying to get into the brain to help with Parkinson's. Unfortunately, you might say that the body likes dopamine a lot and chews it up before it would get actually to the brain. So that's why we don't give anybody just straight dopamine tablets, because it would never make it actually getting into the brain where we need it. The carbidopa prevents the levodopa from getting changed into dopamine until it can get into the brain. It does get changed into dopamine before it gets to the brain, it can cause a lot of nausea. So one important piece then, sometimes when somebody's just been started on the Sinemet, is that if there's not enough of the carbidopa, we do find that someone may get a lot of nausea from that levodopa. So the question is, how much does somebody need? They usually think, and again, everybody's different, but usually the target is to try to get at least 75 to 100 milligrams of carbidopa as that minimum to really help that nausea. So sometimes if somebody's just started on the levodopa, even if they've got the combination, and they don't need very much. So for instance, I saw someone the other day that had a 10-100, 10 of carbidopa and 100 of levodopa 3 times a day. That only gives 30 milligrams of carbidopa a day. That was working pretty well for the Parkinson's, but in someone like that, if there's nausea, we might have to give extra carbidopa. So that may be helpful in that case. Questions about that? Did I put anybody to sleep yet? Oh, yeah, Walt. You put you to sleep or you have a question?
No, you did not put me to sleep.
Okay. All right.
The question I have relates to the protein.
Yeah.
Is there any way of saying how much protein would interfere? And a related question is there a time period before or after having protein that's safe, that you're not going to get that effect?
You know, those are good questions. I'm on the amount, you know, honestly, I guess what's hard about that, Walt, is there's probably not an exact amount where we would say it would start to have an effect, because probably for the most part, if you're looking at any typical, you know, say a sandwich or something like that, I think even a moderate amount of protein can have some effect, but it does come back to that sensitivity level, how much somebody needs of the levodopa. So that probably becomes a bigger driver than the actual amount of protein, if that makes sense. So probably what we would tell in most cases from an actual advice standpoint is that if somebody is having a lot of difficulty, we would try to avoid protein right at the same time as much as possible. Ideally, it's probably, you know, you probably need an hour or 2 of separation, meaning that it usually takes at least 30 minutes to start to absorb a medication, probably an hour to really get most of it in the blood, or, you know, at least moved along the digestive tract before food would affect it. And if somebody has eaten, it probably needs to be about 2 hours after to kind of try to minimize that. But honestly, it'll depend a little bit on what the meal was too. If it was a lot of fat and protein, it's probably going to stay in the stomach longer than if it's a leaner protein, etc. But I would say probably if we can, an hour or 2 would be a reasonable separation. But sometimes we've got to work, you know, as best we can with what's practical as well. Yeah.
Just a question about the Sinemet. How many milligrams of carbidopa does each pill have? So then I would add that up total for the day.
Right. Yep. So you would, to get that total 75 to 100, that's a total daily amount.
Okay.
And
Can I
then
tell on my prescription bottle what I've got?
You can.
Okay.
So this will come as either 10-100 or even a 25-250. So the carbidopa is the first amount.
I was only gonna ask her to repeat the question, but I think just real quick so that those out in the would, because he just gave the answer to the question that was
right. How do I tell how much carbidopa I have in each pill and how much I would have total for the day?
Yes.
I think it's kind of amazing. Sinemet, the people who were brilliant enough to combine carbidopa with levodopa, Sinemet, sin, S-I-N means without in Latin, and the emet means without emesis, without throwing up. And so they were brilliant enough to come up with that, but it's really not enough for a lot of people. And so when their drug went generic, I hear they were furious. And so if you need to take extra carbidopa, which a lot of us do, it's not generic, and it's very expensive, and they're trying to get back at us.
Yeah, and hopefully you all heard that. I'm not sure why the carbidopa alone is not generic. If it should be. I'm not sure why. It should be off patent, but I don't know the answer to that. But yeah, question here.
What happens is you got extended release versus automatic quick release, I guess.
Okay.
So there's a difference. There must be a difference with this kind of formulas or these ratios for that, right?
Oh, good question. Are there differences in the extended release and immediate release? There can be a little bit, although some of the ratios are the same. Well, you've got mostly the immediate release. There's the 10-100, and controlled release, there's the 25-250. Although even with the immediate release, there are some different combinations available. But regardless of which one, that first number is the carbidopa. And so whether it's, in general, whether it's immediate or controlled release, if you're trying to look at that amount of carbidopa, we're not really treating that any differently. So if you've got some combination of controlled and immediate, we would add up that carbidopa. Okay. All right. Am I kind of running behind from? Okay.
We would let you stay here all afternoon.
Okay.
But then we have some singers here who might start singing.
Oh, another.
The prescription you get, can that be changed? Like if you need more carbidopa, can the prescription you get allow more carbidopa in combination with the levodopa?
Well,
or do they come as standard set?
They're mostly all standard. So the only real variation is you've got some that only have the 10 of the carbidopa, and the highest really is 10 per tablet, 10 milligrams. And there are some with 25. So really, that's probably the biggest difference that we have. As Ruth was mentioning, there are the additional carbidopa tablets that can be given, but. So that's what we have to go with.
I just wonder if the doctor could prescribe a higher dose in that prescription, but they don't do that.
Yeah, if it's the 25 already, that's usually the highest that we're going to get on those tablets. But great question. You're making me think. This is good.
From a safety standpoint, what about drugs that are introduced that may conflict with other drugs you're already taking? The example is Azilect. I take that, and I went in to have a surgery with Demerol, and a pharmacist alerted and said that can be fatal. And so a lot of us taking Azilect, I was very thankful that my pharmacist was on top of it and said, you better check into that, because there was a conflict where Azilect by itself was doing fine. Demerol by itself is doing fine. Right. But when they're combined, innocently, you can end up with a class 1 conflict, I guess they called it, where it could be fatal.
Yeah, great question. In Azilect could everybody hear that okay? So Azilect is one that can have some drug interactions fortunately, most of them are going to, for the most part, be okay. And Demerol is one that is very serious, so it's one you have to watch very carefully. If anyone's taken Azilect, you may have had some information about being careful with certain foods, or did you get a little bit of that information? It's kind of one of those things that's a little tricky. The foods are actually very similar to the drugs in that what can happen is that there are certain foods that really just if there were enough taken with the Azilect, that in some cases it could cause somebody's blood pressure to go really high. And that would be one of the problems with the Demerol as well. And so for the most part, though, it's not highly likely for that to happen, but it is something that you usually get some information on and people have to be careful with. And it's also one that, kind of the same way with the drug interactions, that we have to be careful with, especially if you get the Azilect, to look at the list. It'll often list some medications you have to be really careful with, including sometimes they'll even have over-the-counter medications, say Sudafed or even cough medicine, that they'll want people to be very careful with. It doesn't always mean that they absolutely cannot be taken together. It's one that working with the prescriber might say, in this case, if you're taking it for a short time, it might be okay for you, but you want to be aware of that list. And then we'll just try to watch very carefully. But there are some that, when we can, we'll just avoid them altogether because we have another alternative. So Demerol is one of those that they would prefer to use a different pain medication after the surgery. But I know that's fairly general in answering your question, but it kind of comes down to a case-by-case basis because we could look at a fairly long list that could interact with the Azilect, some of which we have to just be a lot more careful with than others.
My pharmacist just recommended that you keep in touch with him because he has software and he'll do a comparative for the safety issue.
Yeah, that's excellent. And I'll take a plug there, something I didn't specifically put here, but keeping your list of medications can be very important. People with Parkinson's are one group I think is very important just because you may be seeing different specialists, and that's where we sometimes run into the most problem. Because I'll ask people, do you keep a med list? And they'll say, my doctor has it or my pharmacist has it. But with what we do, we find often sometimes not all the doctors have all the meds because if the different specialists have added it or the specialist added it and your primary made an adjustment to it, we do run into problems with that. And sometimes the pharmacists don't always have it depending on what's been changed as well. So we will be careful with that. And I won't ask if anybody does shop around at different pharmacies. I know that costs can be there, but we've had people with often meds from 2 different pharmacies, sometimes 3 or 4. There are some people who will, every time they get a prescription, call up Walmart, Costco, Rite Aid to see who has it the cheapest, and that's who they fill it at. So it can be a big problem. So I don't want to promote it just because I'm a pharmacist, but if you can stick with the same pharmacy, it often helps, or at least if you do use more than one, be sure that the pharmacists know everything you're taking.
Dr. Gates, I have a question.
Sure.
One of your earlier slides talked about maybe a half a tablet or a quarter of a tablet. Will the pharmacist let people know when some tablets need that coating and which ones? Am I correct? Some can't be, you cut them in half and you lose that coating?
Yeah, great question. So can you always cut tablets in half? Not always. And the best, you can always ask the pharmacy to be sure. And it doesn't hurt to double check. I mean, if they're telling you it can be cut in half, hopefully that's always been checked first. So we can always double check that. One key though, even if it is a controlled release tablet, if it has a score line as we call it, so if you've noticed that tablet has a line down the middle, that means it's designed where it can be cut. So some of those, even if they're delayed release, are designed so that they can be cut in half. They can't necessarily be crushed, but they can be cut in half because crushing becomes a different game altogether. But we can't always cut everything in half either, so that's where we have to check. Okay? The other one I wanted to talk about just a little bit with Sinemet is the dyskinesias. Some you may be familiar with, and some people will talk about dyskinesia as some of the uncontrolled, you might say larger movements. Michael J. Fox is one example. Sometimes if you'll see him when he's done interviews where he may be kind of sitting in the chair and rocking like this. And, it's been interesting because sometimes you'll hear people say, oh, he's not taking his medications. Look at that. He's not doing a good job. But that actually probably means he took more of his Sinemet before he was doing his interview to make sure he'd be able to talk well and do everything that he wanted. And so we mention that just because this is one thing that, even though it can be tricky, if you're getting that side effect, it doesn't mean that necessarily that's always going to happen. The amount of the Sinemet will contribute to that. So sometimes the dose can be cut back a little bit. It's also one that takes some fine tuning, as sometimes later on in the Parkinson's, to make sure that we're able to do what you want to do, but also not getting some of those side effects. So we just try to make sure we're getting the right amount and not too much. But especially if someone has more recently been started on the Sinemet, it's often a matter of cutting back that dose. Any other questions on Sinemet? Okay. I'll talk about, as we call, the dopamine agonists a little bit. And dopamine agonist, now, Ruth's here, so she can probably, it's not Latin, I guess, but since you're breaking down Sinemet for me, I'm just teasing you. Basically, a dopamine agonist is a drug that's trying to act like dopamine. So where these are a little different than what I talked about with Sinemet is that these can get into the brain themselves. The body doesn't chew them up, and they're trying to act like dopamine, but they are a little bit different. So those do give us some advantages, but also some other drawbacks. One that I wanted to bring up is that it gets really interesting with Sinemet and the dopamine agonists and age. And basically, when younger persons diagnosed with Parkinson's, may be more likely to start on a dopamine agonist to try to avoid some of the dyskinesia. Basically, because we want to try to cut down on how long somebody's taking the Sinemet or that dose. However, as someone gets older, we tend to find that that person will become more sensitive to the dopamine agonist. So sometimes it flips around if someone's diagnosed with Parkinson's later in life, that the Sinemet may get used earlier on because these can be a little bit more of a problem. So there is a list here, and not to just give you a list of side effects, we'll talk about these again in a second. But before we move on, I just wanted to point out, I have dizziness as the side effect, but one thing we worry about is orthostatic hypotension, which is basically that dizziness from the blood pressure dropping when somebody's standing up after they've been sitting or lying down. And this is a tricky one because orthostatic hypotension is a problem just with Parkinson's itself. So Parkinson's tends to cause that, and we give a medication that can actually worsen that particular problem. So it can be, you might say, a bit of a double-edged sword in that we can give a medication that helps other symptoms, but if somebody has a lot of this orthostatic hypotension, it could get worse. So we'll talk about that and a few of the others as well. Did I skip a slide there? I think I deleted one of my slides accidentally. My computer was giving me a couple fits today, so I think somewhere along the line I lost a slide in there, and I apologize. I did want to start with the orthostatic hypotension, though, just because we see that a lot. The big thing there is that it is, as I was just mentioning, that double-edged sword. Sometimes it's a balance of the medication and how much someone can function, even if they're getting a little bit of that dizziness. And also how much the dopamine agonist will help. In some cases, it may be that these just have to be cut back a little bit to the lower dose if somebody's getting a lot of that orthostasis. But we also do watch pretty carefully to make sure someone's getting enough fluid. That's one thing we do run into. If anybody's dehydrated to any degree, that can be a problem. That's going to make everything worse. And to some extent, this is one of those situations where salt may be okay. You hear a lot of times don't get too much salt in your diet. But this is one time where we even have some people with really low blood pressure, we have trouble getting them to eat salt because they get worried what's going to happen. Certainly there's a balance point there if you have someone who has orthostasis, orthostatic hypotension, and also some cardiovascular disease, because we've run into that before where the poor person will say, well, my cardiologist said no salt. My Parkinson's doctor says get more salt. I don't know what I'm supposed to do. And so we try to find the right balance there. And sometimes in that case it may be where we've got to work with the medications a little bit too. But especially the fluid. And one I will throw out just to kind of keep in mind too much coffee or a lot of coffee doesn't necessarily mean you're getting a lot of fluid intake. Mainly because if it's coffee or other drinks with caffeine, if someone's drinking a lot of that during the day, those can actually be a diuretic, which is like a water pill. And so in those cases, someone could actually drink a lot of that and get worse rather than better with their dehydration. So nausea once again, and some of this might not be too surprising, but it is okay to take these with food as well. Carbidopa won't help these. It's because the nausea is a completely different cause than what we talked about with levodopa. But we will take those, or people can take those with food. It doesn't affect the medication. And then also in some cases, it may just be a matter of trying to find the right dose, going slow like we talked about. Another one, the risky activities. Have you heard of this before? They talk about some people getting started on these and they'll start to gamble, or sometimes they'll even go buy like fast cars and start to race or something like that. And not to make light of that, but it's just very interesting because some people are shocked at how different the behavior is. They'll say, this is not this person at all. So it is one that we really watch for. Where I say cut down dose or use different medication, obviously if it was a very low dose and this problem started right away, cutting down the dose won't help. Sometimes, though, it could be that the dose has been increased over time and then that becomes more of a problem. Maybe it worked for a while, but then as the dose went up, those problems start to occur. Another tough one is sleep attacks. And it isn't just a matter of getting drowsy. It's literally where somebody can be feeling pretty good and nod off. And this is a tough challenge in how to manage this because there's not always a lot of warning. And I do have down here about starting slow, which can help, but what's also tough is that it doesn't have to be a high dose necessarily. So going back to where everybody's different in how sensitive they are, some people can get started and they'll notice fairly soon that they can get some of these sleep attacks. So as much as possible, what we'll tell people with these is to try to be really careful. Probably not a good idea to start this right before you're going on a long road trip or something like that if you're still driving. But even shorter trips sometimes have been a problem. Fortunately, it doesn't affect everybody. They say in general it's about 1 of every 5 people. But obviously for those people who are affected, it can be a real problem. And overall, again, we'll try to minimize that dose, but then it may just be a discussion about whether this is a good medication or not, depending on how much of a problem that is. Questions about that? Yeah.
Can you, up here the heading says dopamine agonists.
Mm-hmm.
You don't get that with Sinemet?
Great question.
I suffer from that orthostatic hypotension or whatever it is.
Oh, great question.
I don't take Requip, I don't take Mirapex, or I don't take any of those. I take Sinemet.
Great question. So you're asking specifically more about orthostatic hypotension and the Sinemet. So can that happen? It can. The part of the reason I have it up here for this is that it tends to be more of a problem with the dopamine agonists, but it can happen with Sinemet. It's also a challenge because Parkinson's itself can cause orthostatic hypotension as well. So what we look for there, of course, is does it get a lot worse if we can tell after the Sinemet's been taken. You know, if we notice somebody's taken, especially the immediate release, if we notice they get a lot of orthostasis right after that, it can be with the Sinemet as well. So I only mention it, I guess, in that balance is that if somebody is getting that orthostasis as well, the Sinemet is still considered a better choice than a dopamine agonist, and usually the prescribers wouldn't try to shift it all because they would say, you'll try to get by with if the Sinemet seems to be making it worse, get by with as little as we can, but then try to do those other things to bring the blood pressure up if we can. As you may know, in some extreme cases, kind of tying in with that, even though I didn't mention it here, there are even a couple medications that are used specifically to treat orthostatic hypotension, and for the most part, they're just increasing blood pressure. One of those is Florinef, which it's a steroid. I know that can be a little scary. It's not like what the football and baseball players get in trouble for. Obviously, I'm never going to get in trouble for those. But different kind of steroid, it helps. It basically causes the body to retain fluid. So sometimes that's helpful. Sometimes in some heart disease, we have to be very careful with that. Another one is called Midodrine or Proamotine. And it actually does the opposite of some of our blood pressure meds. It actually kind of constricts the blood vessels a little bit. But those are possibilities sometimes if the orthostasis is too much of a problem and there's not, especially again, the heart disease is one we have to really watch for with some of those. So we can't always give those to someone, but sometimes will help. Other questions? Oh, yeah.
Are you going to make these slides available to Cindy?
Yes, I will.
Because I think I've never seen any of this stuff from the doctors.
Okay.
I think it's quite useful for some of us to at least ask more intelligent questions.
Sure, and that's the whole goal, so I'm happy to provide that. I'll even see if I can find.
Can you tell me what? We were wondering what Mirapex is.
Oh, Mirapex is one of the dopamine agonists. So if you've seen it by generic name, that's Pramipexole. There'll be a test on that afterward. You have to answer that question to get a cookie from the back.
What do you recommend for difficulty sleeping?
That is a great question. I will say what I'll say, I know this is a very general answer, it does get a little bit tricky. And why it's a little tricky is that there is a whole range of different sleep medications that, depending on how much trouble someone has, there's different ones that might be okay. And you see a lot of some like Ambien or Lunesta, which is the butterfly med that helps you sleep. Especially, it seems like if you watch Jeopardy or Wheel of Fortune, you'll get a lot of that. Those can work well for some people. Although there are some people who've even had some trouble with, say, sleepwalking or a little bit of amnesia where they'll get up during the night. But some people do very well with them. There are some prescribers who prefer trazodone, which is an older medication for depression, which often wasn't used much for depression because it made people too sleepy. So somebody finally figured out, hey, let's give it in a lower dose and use it for sleep. Sometimes that does work pretty well also. And sometimes, though, if you're really worried, say somebody with falls, there's even been some people who do try some of the melatonin. Sometimes that doesn't work. Everybody's different again. So that can be helpful for more mild sleep, but it usually has to be taken a little longer before going to bed. Some people even have to take it a couple hours before. So it may not work for everybody either. But what about exercise? So exercise, if it's too soon before bed, so can be different for each person. And probably in the evening hours, usually for most people, would keep them a little bit more awake. But exercise earlier in the day tend to help people sleep better. But
Is it,
oh, go ahead.
Does exercise tend to promote less drug, like dopamine? Would the goal be to, does exercise do anything that symptoms, your symptoms may be going? I don't know what I'm talking about, but I work out a lot, and I just wonder what advantage that is other than the pure physical activity.
Sometimes exercise will do more than some of the medications will do. And, you know, there's, with Parkinson's, obviously, you've got effects on the neurons within the brain and some of that control. But one thing that Steve Setter taught me is what we call a reserve capacity. So basically what that means is within the body for anything, whether it's your muscles or even, say, our kidneys, things like that, that in general the body has some extra capacity. So sometimes even if people didn't always take care of themselves when they were younger, you know, they might say, well, I don't need to take care of myself. Look, I've been drinking for years and not had any trouble or something. But as they get older, that may manifest a little bit more. So what does that have to do with what I'm talking about? Same way with exercise. The more that, say, someone has with strength and flexibility, even if, you know, that won't necessarily stop what's going on within the nervous system for Parkinson's, anything we do increases that reserve capacity so that if someone is affected more by the Parkinson's, that extra strength and flexibility and endurance from exercise can always help. So when somebody can, that can really help Parkinson's a lot. So the answer is yes, I hope. Hopefully I answered the question right.
I take pramipexole and it results in very vivid bad dreams and long running dreams that are very realistic and things like that. Is there any way of controlling that or reducing that, or would you recommend replacing pramipexole with something else?
You know, there's probably not much that could help to actually get rid of that. The one I didn't mention with the dopamine agonists specifically are some of those dreams, or some people even feel like they're getting hallucinations or they'll see things. If it's hallucinations, sometimes there's a medication we can give, but we'll try to avoid that as much as possible because those medications also run the risk of making the Parkinson's worse. So usually we'll try to see if we can get by with a lower dose or switch the medication, as you were asking, to something else. If it's one of those situations between, say, the amount of Sinemet or use of Sinemet and the dopamine agonist, Sinemet will tend to cause less of that, although it still can. But probably switching the medication is the best way to get around that. Did that help a little bit?
Yeah, that's fine. Thank you.
I was just going to ask if we're going to be able to go. Like we would be here all day long with all the questions, and we really want to. But I was just going to ask real quick how many slides you have left, because I want to know what you're going to present. I want to know that information too. The questions are important, and so.
I have 4 more slides.
Okay.
So an hour for 12, I guess we can take that for.
Yeah, no, that's great. I don't want to hurry you. I just, how about we hold questions now until the end, if you're okay with that?
Sure.
And let's do your slides, and then we'll go around to ask all of the sites for questions, and then we'll sing along.
That sounds great. I think these last ones will be a little quicker. So
okay. No, I'm not. No hurry. It's a lot of really good information. So we, like Walt just said, we need you back almost every month. So. Yeah. Thank you.
Well, one I wanted to mention quickly is Comtan or entacapone, which some of you may know it's sometimes added to Sinemet, and it can come in combination as well. There is a combination tablet. It helps with the wearing off, as you'll see there. The big side effect that we like to tell people about, or hopefully they're told about, is that it can turn urine or sometimes sweat, tears, kind of orange-brown. So that one of those things that can be pretty scary, especially in the urine. That often scares people as to what's happening. That is normal. So it's nothing. It's really just a color. It doesn't mean that anything's wrong. Not our favorite, but not one to be concerned about. Selegiline wanted to talk about briefly, and we kind of hit on this a little bit with rasagiline and the drug interactions. Selegiline and rasagiline are very similar in terms of the way they work. They actually, kind of on a simple level in the brain, keep the brain from getting rid of dopamine. Normally, we call neurotransmitters in the brain that the body has. There's kind of a recycling process. On a simple level, the body tries to keep things fairly fine-tuned, so it will release neurotransmitters when it needs them and then pull them out of the way when it's not. That's why the body is much more efficient at doing things than we can with meds, because we give something and it stays around for a while. But basically, since there's not enough dopamine in Parkinson's, it's trying to allow the dopamine to stay around longer. So it's a different way to try to treat it. The problem where the drug interactions come up is that it doesn't affect just dopamine. There's other things such as norepinephrine, which is adrenaline, and you may have heard of serotonin before that's in the brain. Those are affected as well. And on a simple level, it's that broad effect that can cause problems with medications, and also tied in with certain foods that we talked about, the aged foods, the cheeses, and some of that. I will say that selegiline and rasagiline are less likely to cause those interactions than some very older medications that we had that were used for depression. And as long as we keep them at lower doses, so for instance, the selegiline, if we keep it no more than 10 milligrams a day, we're not as likely to see those problems. From a side effect standpoint, you'll see here why I wanted to talk about those, especially the selegiline, is that there are some people who have trouble with insomnia or even anxiousness. They feel just kind of more, you might say, wound up. And part of that, as I mentioned, it could affect adrenaline. And I don't mean to scare anybody here, or since this is recorded, cause any problems, but selegiline actually, from a pure pharmacologic standpoint, gets changed by the body into amphetamine, which are medications that are stimulants. So I only mention it there because some people are like, oh, we better not, drug of abuse, we better be careful. It's not so much that gets abused that way, but it can keep people awake. I mean, it's essentially a medication, or it's similar medication that will keep people awake. The rasagiline, even though it's similar, doesn't keep people as awake as often. It could have some similar side effects, but they're more mild. So sometimes that gets used instead of selegiline if selegiline looks good and people had trouble with it. But as you'll see there, it is more expensive. So that's why some people will use the selegiline first. And then the amantadine also, notice the sleeplessness there, insomnia. It's kind of like the selegiline. This is kind of interesting too. Amantadine also gets used, and some people with multiple sclerosis, because they often get very fatigued. And some neurologists will actually give them amantadine to help them stay awake and not feel fatigued. So it works well for that, but interestingly enough here on the flip side, if you're giving it to someone maybe who isn't having sleep problems, you can have the opposite effect and keep them awake. And like a lot of other things, it can cause nausea, not to the same degree, but food's also okay with that. And then my last one I wanted to mention briefly are the anticholinergics, so big word. And there's a few examples here you may have heard of before, Artane, and one I threw in at the end, Benadryl. But these get used in Parkinson's sometimes to help with tremor. If somebody's really having a lot of tremor, these can get added on. But they're a fun group, and I have a whole list there: confusion, dry eyes, dry mouth, constipation, urinary retention. And basically what these drugs do is that they're, as we call, the opposite of the rest and digest system. So, you think about somebody relaxing rather than saying running away from a bear, being active. So this does the opposite, though, of that resting. So it slows down the digestive tract, makes urine harder to go to the bathroom, and also causes some confusion. And then the dry eyes and dry mouth. Why I want to point these out, though, just so there's some awareness if you're using those, especially noticing here how Benadryl is over the counter. Some people don't realize it's in medications and even use it for sleep sometimes. But we've even had times, people get worried because they've started on some of these and they get very confused and they say, oh no, I'm getting Alzheimer's, I can't remember, I walked into the room, didn't know where I was. Or sometimes a family member says, oh no, look what's happening. But we try to look at medications too, just because sometimes that is a problem. So I only bring that up for awareness. Not everybody gets that. So again, everybody's going to be a little different, but something that we do watch very carefully. And doesn't mean that they cannot be used, but we just have to watch for those side effects. One I have down here, and now looking at the slide, it's a little confusing. We use those for tremor, but another one in some people with Parkinson's is if there's a trouble with drooling, these medications will get used because it helps with, it causes dry mouth, so it can be helpful. Sometimes, though, if someone's needing this, especially say for drooling, and confusion has been a problem because they'll cause that. One that has been used is called glycopyrrolate. And on a simple level there, what happens is glycopyrrolate can't get into the brain very easily like these can, so it doesn't cause confusion. It'll help with dry mouth, and it could still cause some of these other things like constipation and urinary retention, but sometimes it's a little better tolerated for the drooling. And that was my presentation.
I'm glad you kept going to that last slide. Now I want to keep you up here, and it's like a doctor's appointment. I want you to be here so I can. That whole last slide just made me think a lot. At our locations, we're going to do real quick. We'll go through our different locations that have checked in today, and if you're still there, that's fabulous. And if you have a question, let us know. And then at the end, if you would like to join in again with our Tremble Clefs and do a sing-along, we would love to have you do that as well. And so Anchorage, Alaska, how many people do you have today? Okay. They did, but they might be checked out already. Billings, Montana.
We have 4 today, and very good presentation. Thank you.
Thank you, Billings. We're glad to have you today and always. Chewelah. How many people today? And if I skip you or you're trying to make the equipment work, it happens to the best of us, and so just hop in there and we'll take care of it. Clarkston, Tri-State Memorial.
6.
Thank you, Clarkston. Coeur d'Alene, Kootenai Medical Center.
Coeur d'Alene has 3. She must be in a different room.
Who must know?
There's only 3 of us in here.
Okay. Did you have any questions?
No.
Okay. And I had 2 down for Colville. And Dayton. Did we have anybody at Dayton today? And Kennewick. And Miles City, Montana.
Yes, this is Miles City, and we had 12 happy smiling faces.
Hi, Miles. Miles City, are you going to stick around for some sing-along with us today?
They're not. Nobody here sings bass, so we can't do that.
I don't think you have to be able to do bass. We'd love to have you stay.
Okay.
Do you have any questions today?
Anyway, no, but it was a good presentation. Thank you.
Thank you so much, you guys. Pullman Regional Hospital.
There are currently 5 of us here today. I have a question. I just recently received an invitation from a Canadian pharmacy to purchase Azilect for $360 odd for 90 days worth of pills. They did say that it was probably made in India. Is this a safe thing to even consider? My regular pharmacy is charging me about $1,600 or more for the same amount of Azilect.
Okay.
Wow, that's a good question. I'll be honest, it's a little hard to know sometimes when it's made in India. There are good companies over there, but there's not quite some of the quality always. The challenge is if it's brand name, if there's only one company that really makes it. So even if it's coming out of India, that means that if it's really the true brand name, it was made by the original company and then it's kind of being resold to you after it was shipped to India through Canada. So
I suspect that from the other literature that this is what they refer to as a generic form. I've never been aware that there was a generic form of Azilect available legitimately.
I didn't think it was available yet. I looked before I came just to check, and I didn't see that there was a generic available. So unless they did have a generic that got approved in one of the other countries, sometimes that will happen. It may not be the actual same medication. That's always the concern.
Yes. There is another question. Does taking Azilect and Sinemet in any way interact with aspirin, Aleve, or any of the other NSAIDs, which can be used for control of arthritic problems?
Those are okay to take together. At least normally we wouldn't be concerned about that. Unless, did you see something in particular that those would be a problem?
No, I merely have been told I should not take it because at my age it's dangerous to take it.
Okay.
And they didn't know if there would be a problem with the other medications. I haven't been able to find any reasons pro or con other than at your advanced age you shouldn't take it. Makes me nervous.
Sure. And shouldn't be a problem from an interaction standpoint. What they get worried about with the NSAIDs, ibuprofen and others, is if somebody's had stomach ulcers in the past, heart failure, or kidney issues. Those are really the big ones. But otherwise, from an interaction standpoint, it would be okay.
Thank you.
You're welcome.
Thank you for your questions. Tenasket, North Valley Hospital.
Hi, there's 3 of us. Thank you for the presentation.
Thank you. And Walla Walla, Providence St. Mary. Okay, I think we're ready for a sing-along. Do you think?
No,
one more.
you skipped
She's in
Moses
Spokane.
Lake.
We have 27 here, by the way.
Okay, but I just heard. Okay, Pam, we will answer your question in just a moment. I skipped somebody that I didn't know about. So, who did we skip?
Moses Lake?
Oh, how did I do that?
I can't imagine.
I can't either. Sheesh.
We have 13.
Awesome.
And one question, very quickly. How do nicotine patches affect tremor?
Good question. Want me to come up here?
You can if you would like, yeah.
Okay. Now that you get me focused, I'll move around. You know, the nicotine patches, and I'll throw this out and tell me if there's a particular, if there's more specific information behind the question. Nicotine itself, especially if it's in a high enough dose, could cause tremor that might be unrelated to a tremor from Parkinson's. The other tricky part of that, there are sometimes nicotine may improve some of the symptoms of Parkinson's though as well. But was there anything more to the first question?
Well,
anything you?
I read an article by a man who had Parkinson's and had a considerable tremor. He measured it to be an inch. And he has highly successful results with nicotine patches. He puts on one a day. He cuts the highest dose in 3 parts and puts it on and says he doesn't tremor and has no high blood pressure or heart arrhythmia from it.
Okay, yeah. Well, it's, you know, I don't know how many people have had that work, although it's one of those strange things, or even though we wouldn't even encourage people to smoke, that they've noticed sometimes people who smoked and also were diagnosed with Parkinson's, oddly enough, sometimes had their Parkinson's symptoms get worse once they stopped smoking, and that's where some of the thought to the nicotine came in. My guess would be that it may very well help some people, and the basic idea, nicotine does work in the brain, as I was mentioning, could affect, cause tremor in some cases if it's too high, but it also may help just with some of the, you might say, getting the signals right in the brain. So probably for some people it may actually be beneficial in helping with the tremor. But I don't have enough experience with it to tell you how many people would or if it wouldn't help everybody.
So it's worth a try.
Might be that, you know, it's probably wouldn't be covered by any insurance because even the nicotine patches are all over the counter now. And you do have to watch. I'm glad you mentioned about the cardiac effects too. That's something we do have to be careful with, especially if somebody hasn't taken nicotine or didn't smoke before. We do have to be really careful with that. Much like somebody who's stopping smoking cold turkey, both getting too, I should say stopping smoking cold turkey, or if they're smoking too much, you can have effects both ways there. Nicotine gets a little bit tricky. So we have to be very careful with that. I would, even though it's over the counter, I'd really encourage people to talk with their prescriber just so it's monitored a little bit, make sure somebody's not getting too much.
Another question, marijuana. Now that it's legal here, what can we do with it? Would it help?
Am I allowed to answer that question? No, I'm yeah.
On the list of pharmaceuticals yet that
you know, I'm not aware of specifically that marijuana would help Parkinson's specifically. I mean, obviously there's things that go along, anxiousness, nausea, those type of things. And somebody could correct me if I'm wrong. Sometimes I get an earful when I say something about marijuana. That's okay too. It is one of those things that certainly there, you know, from the scientific side, we know there can be benefits. Obviously, there's some challenges with, since it's not always well controlled what somebody's getting. But I'm not sure it helps the symptoms specifically.
Oh, we just had a sarcastic statement here. How about for the caregivers?
Yeah. So one of our movement disorder specialists here in town had that question one of the last time he spoke. And what he said about it is just remember that marijuana's effect usually is something that slows people down. And so if you're already having issues with slowness or bradykinesia with your Parkinson's, then marijuana might not be something that you would work for you. So, but other than that,
Might be dead.
it is a question we have to start looking into a little bit more because here it's more available. So, yeah, good question. Okay, Pam, and that's Pam's our. Thank you, Moses Lake. Well, thank you very much. We have one last question.
Okay, my drug interaction. I take amantadine, and I recently had to reorder the trihexyphenidyl, and so I read it because it says drug interactions, especially amantadine. What does that mean? I mean, trihexyphenidyl interacts with amantadine. I immediately called the doctor, and he says, well, you don't take enough of it to bother about. But what does that mean? How much of a warning is it from a pharmacist's point of view?
Yeah,
oh, hello, folks.
You know, offhand, I can take a look. Offhand, it's not one I would be concerned about if I saw the two together. I'll double check. I've got my little cheater, but it's not one that at least see what they're saying about that. The hard part, and dose is one of the things that does come up with some interactions where your doctor mentioned you're not taking enough to be a problem. There are sometimes those things that aren't really a problem unless you get really high doses. And then the other thing, especially if you've been taking something together for a long time, we're always looking at, okay, have you had any effects or not? So unless you started taking them together and notice anything strange happen, that might not be a problem. And the other piece where the drug interactions get tricky is just, again, what I mentioned, everybody's different. So there's a piece of that, just as we mentioned, people are sensitive to drugs. Sometimes the interactions will be that same way, where you can get some people that take the two medications together and will have a problem, and others will never notice an issue. But I'll take a look at that just to see if there's anything else I should be telling you about that. But it's not one that shows up as a big warning.
Yeah. Oh, yeah. Thanks.
Okay. Well, you going to start everybody out?
Okay. Thank you, Brian. Controlling Parkinson's is so dependent upon the medications that we take. We could easily have you come every month and have plenty of questions for you, and we'll have to try to plan in the future to have focused presentations on specific aspects of the drugs that we have to deal with. But I'm sure we'll be inviting you back again.
Sounds good.
Okay, folks, the Tremble Clefs, just a little note about who we are. The Spokane Tremble Clefs were founded. This is our 10th year of operation, and one of our co-founders, Ruth Polnick, is in the audience with us here too. And it's a group of folks with Parkinson's and their caregivers, and we get together once a week and we sing popular songs, and it's therapeutic in that it helps us with our voices, and it's also a good social interaction. And we also do many performances throughout the year at various community events too. Later on this month, next week, we'll be performing at the Christmas Bureau at the Spokane Fairgrounds, where Catholic Charities gives out a lot of goodies to those who are in need. And we do performances like that throughout the year. And, for this particular performance today, we'd like to dedicate this to Ed Ewell. Many of you may know who Ed was. Ed was a founder of the Parkinson's Resource Center here, and he's the guy, he was a pharmacist who initiated this telehealth, this monthly presentation. And he passed away last year. So we'd like to dedicate this performance to him. And I'll introduce Pam Baldwin, our director, and she will get us started. And we have Donna Douglas tickling the keys over there. Okay, join in, please.
We're delighted to have you with us, so just sing along. You probably know every single one. Oops, Walt, this is not happening.
No, doesn't want to go. Oh, dear. Okay.
It's not moving.
It's paradise. It's stuck. Is this a PowerPoint? Yes.
I think we could start the first
no,
one.
wait a minute. I wonder if that's...
While they're working on this, we'll sing Deck the Halls, because I think you probably all know it.
Can we get out of this? That's not, it's stuck.
Deck the halls with boughs of holly, fa la 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 la. 'Tis the season to be jolly, fa la 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 la. Don we now our gay apparel, fa la 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 la. Troll the ancient Yuletide carol, fa la 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 la.
Very good. Go to the next slide.
See the blazing Yule before us, fa la 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 la. Strike the harp and join the chorus, fa la 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 la. Follow me in merry measure, fa la 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 la. While I fill up Yuletide treasure, fa la 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 la.
Great, I even see some smiles. Excellent. Let's move on.
Just wait, you might see some dancing.
Good, good.
Have a holly jolly Christmas. It's the best time of the year. I don't know if there'll be snow, but have a cup of cheer. Have a holly jolly Christmas. And when you walk down the street, say hello to friends you know and everyone you meet. Oh, the mistletoe hung where you can see. Somebody waits for you, kiss her once for me. Have a holly jolly Christmas, and in case you didn't hear, oh by golly, have a holly jolly Christmas this year.
Very nice. Joy to the world. We're going to skip this one. Right there.
Joy?
Yeah. And we're only going to do the first verse. Okay. We're just going to do the first verse on Joy to the World.
Joy to the world, the Lord is come. Let earth receive her King. Let every heart prepare him room, and heaven and nature sing, and heaven and nature sing, and heaven and nature sing.
Yeah, he's coming.
Here comes Santa Claus, right down Santa Claus Lane. Vixen and Blitzen and all his reindeer pulling on the rein. Bells are ringing, children singing, all is merry and bright. Hang your stockings and stay
Skip and Frosty.
We're going to jingle. I know. We'll have to sing Frosty in January.
Jingle bell, jingle bell rock. Jingle bell swing and jingle bells ring. Snowing and blowing up bushels of fun. Now the jingle hop has begun. Jingle bell, jingle bell rock. Jingle bells chime and jingle bells time. Dancing and prancing in Jingle Bell Square. In the frosty air. What a bright time, it's the right time to rock the night away. Jingle bell time is a swell time to go gliding in a one-horse sleigh. Giddy up, jingle horse, pick up your feet, jingle around the clock. Mix and mingle in a jingling beat. That's the jingle bell, that's the jingle bell, that's the jingle bell rock.
Oh, nice. One more. Oh, no, right there. Okay, we're going to have White Christmas. Maybe we'll have one. I'm dreaming of a white Christmas, just like the ones I used to know, where the treetops glisten and children listen to hear sleigh bells in the snow. I'm dreaming of a white Christmas, with every Christmas card I write. May your days be merry and bright, and may all your Christmases be white. Very nice. And we're going to close with We Wish You a Merry Christmas.
We wish you a Merry Christmas. We wish you a Merry Christmas. We wish you a Merry Christmas and a Happy New Year. Good tidings we bring to you and your kin. Good tidings for Christmas and a Happy New Year. We wish you a Merry Christmas. We wish you a Merry Christmas. We wish you a Merry Christmas and a Happy New Year.
Well, if you enjoyed that, just come and join us at Parkinson's Choir anytime you want. We meet on Tuesdays at 1 o'clock at the PRC Center.
But not for the rest of this month.
Oh, right.
Starting in January.
Starting in January.